Okay, any questions from the first half? I feel comfortable with their opioids. If I need to reverse an opioid, what do I give? Narcan, naloxone, absolutely. Okay. All right, let's start off with our rheumatology talk. Have you guys covered rheumatology at all? Yes. All right, we're mainly going to focus on RA, and then we'll kind of lump in osteoarthritis along with this, just because although the pathophysiologies are very different, you know, the manifestations of pain in the joints is similar. We'll see kind of compare and contrast the way we're going to be treating this, right? Super in depth on the basics of it because you guys have covered it already. But what is RA basically? Okay, so we're having inflammation of the joints and the synovial. Why are we having that inflammation? Good, it's an autoimmune condition, right? So it's good we've already covered GI because we were going to see that the treatment is going to be very similar. You know, MS. Again, these are all autoimmune conditions, and so we're going to know that, you know, for like acute flare-ups, how do we treat that? Steroids. Yeah, steroids are going to be a go-to sort of drug for a lot of acute flare-ups. We're going to see that there's also disease-modifying therapies similar to what we saw before, right? What other type of drugs do you think we're going to use? Well, for rheumatoid arthritis, based on what we know, yeah, so NSAIDs are going to be good, but specific to talking about autoimmune conditions, we're going to look at our monoclonal antibodies again. These are going to pop back up, right? Because again, these are very targeted at being able to inhibit inflammation by dealing with things like tumor necrosis factor or interleukin and things like that. So keep those in mind. We're going to talk a lot about those because those are going to be good at helping with disease modification, right? Helping to slow down progression of the disease. Because again, that's the big thing we're trying to do here. We want to slow down. We obviously treat the pain the patient's experiencing, but what's the problem with RA over the long term? What happens to their joints? They get deformed. Their ability to perform activities of daily living go down. It can be huge impact. And again, is there any way we can like fix it? The problem? Is there any way to reverse it? Not really, right? You know, it's nice for, you know, things like osteoarthritis. I can just take your knee out and give you a bionic knee, basically, and now you're part robot, and now you're part. No, I'm just kidding. It's not really, but I can give you a new knee. I can give you a new hip, but a lot of times for RA, like we can't really do that necessarily. So again, the big thing here we want to do is just try to slow down the progression. We can't reverse anything, but if we can slow it down and hopefully keep function of those joints for as long as we can, right? So that's the main goal here. Mainly what we're talking about. However, the main thing here is that there's a lot of inflammation. There's a lot of inflammatory cytokines being produced here. This is why prostaglandins are big, right? Which is why we're going to see NSAIDs are going to be very useful here to help with that kind of inflammation happening locally at the joint. Again, we're not able to really differentiate ourselves from foreign antigen, so that's why it's an autoimmune condition. We're attacking ourselves. It just happens to be the joint that really takes the big hit here. So anyway, I'm not going to go over all the detail of this. Just know that we're seeing a lot of activation of B cells and T cells. These are going to be big targets for a lot of our monoclonal antibodies, and especially those cytokines that help to activate them. So things like tumor necrosis factor, things like interleukin that are working to activate some of these inflammatory cells are going to be a big target for those antibodies. Anyway, let's see. So you can just kind of looking at what this kind of reaction is happening here with all these different activation of different inflammatory cells, kind of really just eating away at the joint itself over the long term. So again, if we can inhibit this by interrupting different steps in that process, we're going to be able to decrease the inflammation and decrease that destruction of the joint in the long term. Versus osteoarthritis, what's kind of the issue with osteoarthritis? Aging, yeah, that happens with aging, but what's kind of the pathophysiology? How does it compare to RA? Just wear and tear, right? It's going to happen to everyone on a long enough timeline, right? That you're just having that. Eventually, you're losing that cartilage. You're having that bone grinding on bone. Eventually, it causes a lot of pain there. And so, how do you think the treatment would differ between RA to OA? Yes, we can do surgery on these people. We can replace the joint. Is there any way to kind of slow down the disease process? That's going to be more with osteoporosis. We'll talk about that eventually. Yeah, so we're going to see that there's not as good of a chance to kind of slow down the disease process because, again, here, the more you're using the joint, the more you're going to have the damage being done. So we'll find some ways to get around that. We'll talk about some means that we think may be able to help with that. But in general, we're not going to see the same kind of disease-modifying therapy as we will for RA, right? So for RA, we're going to see that there's, you know, kind of symptomatic management. There's things to slow down progression. With OA, it's not going to be so much of that. It's going to be more of just kind of treating the actual manifestation of the disease. Because ultimately, the thing we can do is replace the joint, like in a lot of cases. But like hand osteoarthritis may not be as big of an option, but certainly like knee, hip, things like that, we can certainly replace that. And just kind of compare a normal joint versus looking at something one with osteoarthritis. Again, just bone on bone, causing a lot of that pain happening there. Versus with RA, it's a lot of inflammation. Usually the cartilage might still be intact, but all this inflammation, all this swelling, causes a lot of deformation over time. Okay, so let's see. You guys have covered osteoarthritis as well, correct? Okay, so we can talk a little bit more about that. But again, you guys kind of have the gist of it. We're going to see this articular damage being done over time, sometimes due to injury, but more often just due to stress and kind of wear and tear over time. Basically, you're going to see one of these chondrocytes that are useful for producing new cartilage kind of just become apoptotic over time and will kind of destroy themselves. And the big thing you're going to see is that we're having a lot of activation of these nociceptive nerve endings. So the inflammation here is not going to be as widespread as you might see with like an RA, because with like RA you see a lot of like kind of extra joint manifestations as well. So you can see sometimes some bleed over into other areas. With osteoarthritis, it's really kind of localized just to that joint. And so again, how we treat this will depend on how many joints are being affected, how widespread it is. So for instance, if it's only the knee, like say the right knee is being affected, I can use a lot of local therapies that are right there that help to limit systemic drug exposure, right? Versus with rheumatoid arthritis, it's more of kind of a systemic issue, and so you're going to find more systemic use of medications there. But we'll look at some examples and how we can kind of compare and contrast, multi-joint OA versus just kind of single joint. So anyway, you're seeing kind of more damage done over time. Again, you're seeing the kind of narrowing of the capsule there, a lot of damage to the actual the cartilage over time. All right. So anyway, so our goals for kind of both conditions to get into the drugs is to try to relieve pain and stiffness. We want to try to get rid of that inflammation. Again, with OA, it's not always going to be inflammation present. It may just be kind of more just pain from the actual mechanical issues there. But reduce inflammation and try to improve function, right? So if we can try to get them moving around more, that's going to be the best thing for them, help improve quality of life, and try to slow down that joint damage. With RA, we know just like with other autoimmune conditions, you can have kind of flare-ups. You can kind of have peaks and valleys in their symptomatology. So we'd like to have remission of symptoms and try to slow down the disease progression. So one of the biggest things these patients can do for themselves is physical therapy. But does everyone like to do physical therapy? No, it's hard work and it hurts. I don't want to do it, right? So again, this is one of the big things we run into. But certainly, there's a lot of aqua exercise, aqua therapy, things like that can be very useful. Stretching, strengthening. Really try to encourage this as best you can. Work with your your PT friends and your OT friends to try to help with helping to strengthen these muscles and helping to regain that function. Weight loss is a big thing, especially if you imagine if you have osteoarthritis, you become more sedentary. What do you think that does to your weight? Goes up, right? And that makes you more sedentary and can increase wear on the joint. And so you see this kind of sick cycle happening there. So weight loss can be a big deal. Assisted devices are good, rest, and then obviously surgery in the case of OA is going to be one of the kind of the final therapies you can attempt with that. But looking at comparing the treatments here, we're going to find that with chronic treatment for RA, we're just going to see the NSAIDs are going to be a big mainstay of therapy. We're also going to see low-dose chronic corticosteroids. And we mentioned with corticosteroids, how long do you want to use those for? Shortest time as possible. Here we're going to find that for some of these patients, the more severe, you may need chronic low-dose corticosteroids. So you have to kind of deal with the side effects, but it's the only way to really get that inflammation in check. Versus with chronic treatment, you're going to find more use for acetaminophen with osteoarthritis, with NSAIDs. And we'll look at some topical analgesics like capsaicin, which we just mentioned. And then for acute exacerbations, you're also going to see this is very different. So for instance, with RA, corticosteroids are the best thing to do because we know that inflammation is being turned up. We need to try to dampen that by using IV corticosteroids, right? Versus an acute exacerbation for osteoarthritis, more likely to do something like an opioid, right? Or maybe like an IV NSAID or something like that. You need to kind of look at the pathophysiology and kind of treat based on why they're having this kind of acute symptoms. We'll look at DMARDs. Anyone know what that means? Disease modifying anti-rheumatic drugs. Yep. So we'll look at DMARDs in a little bit. Those are going to be very slow acting, but they are going to be good for slowing down progression of disease. And then we'll also see that for both of them, we can actually do some neofusions as well. So things like aspiration of the joint can be useful, especially if it's very swollen and inflamed. And we'll also get some corticosteroid injection as well. Remember, who gets RA usually? What type of patients? Who gets RA? Yeah, you think older women potentially? Do little kids get it? Yeah, absolutely they can. Yeah, so we had some cases. I remember seeing this one kid who whose knee was just humongous, coming into the ER and the rheumatologist coming down. They're going to do an aspiration and then inject some corticosteroids. And I remember the guy was just pulling off just 60 ml, 60 ml, 60 ml out of this kid's joint. It was just amazing. I was like, how does that much fluid fit in that space? He must have pulled off near 250 mLs off this kid's knee. It was insane. But the kid felt a lot better afterwards, right? All that pressure was off of there, and then he got to inject the corticosteroids. But it's very kind of interesting to get to see that. But anywho, so we'll see there's lots of different options, especially when you're dealing with specific joints, things like the knees especially. So with RA pharmacotherapy, we're going to see these disease-modifying anti-rheumatic drugs are going to be kind of mainstay. These are going to be good chronic maintenance therapy to slow down disease progression. We're going to find they can fit into two categories, either biologic or non-biologic. Which ones do you think the monoclonal antibodies fit into? Yeah, those are your biologics. When you hear biologics, think monoclonal antibodies. We'll look at the non-biologic, which are typically our older agents. And then we'll see that we want to start these as soon as possible because that's going to help to save the joint for as long as we can. And then for more immediate sort of acute pain, inflammation, NSAIDs and corticosteroids are going to be a lot better for that. Okay. So our traditional DMARDs we're going to cover here include things like methotrexate. Remember where else we use this? It's a folate antagonist used for cancer. Yeah. So what do you think of the doses between methotrexate for cancer versus for RA? I think it's lower or higher for RA? A lot lower, yeah. So typically you're going to see for autoimmune conditions, you're using a lot lower doses of these because, again, when we're giving it for cancer, we're trying to wipe out the entire white blood cell count, right? Versus here, we're just trying to help to dampen its effect a little bit. But everything we knew before about methotrexate still applies here. I'll look at a few other drugs called hydroxychloroquine, sulfasalazine. You guys remember covering that before? Or we talk about that? Remember ulcerative colitis and Crohn's, right? We saw sulfasalazine there as well, so it's coming back to bite us in the butt, right? We also have leflunomide, which is, again, is also kind of a cousin to a chemo drug. Teriflunomide, we talked about that one during MS. So, and then looking at the biological DMARDs, we'll talk about, again, I'm going to only cover some of these in detail. There's so many of these new ones coming out every single day that it's hard to keep up with, but we'll cover some of the ones we see more commonly. So things like infliximab or Remicade, adalimumab or Humira. Those are two of the more common ones I see being used, but there's lots of them that are out there. We'll cover a few more than that, but whatever I cover in detail in the upcoming slides, those are the ones to focus on for the test, okay? There's also some interleukin-6 receptor antagonists, things like tocilizumab and rituximab. And then there's a kind of a new classification here we'll talk about called tofacitinib. And this is actually a new novel mechanism, so we'll go into detail on that just a little bit here. Okay, now some of these ones here don't need to know them for the test specifically, but we have used them occasionally in the past. So we have things like cyclophosphamide. Remember that one? Where do we talk about that? For cancer, right? We use that for cancer. It's an alkylating agent. Again, similar in effect to methotrexate. It can help to tamp down the immune system a little bit to try to decrease that inflammation. But again, we're going to see lots of problems with these drugs. What do you think is a big problem with using something like cyclophosphamide? Yeah, maybe cystitis. Yeah, but more from an immune standpoint. Risk for infection. Remember, anytime we're dealing with the immune system, we're trying to inhibit the immune system, our risk for infection is going to go up. So this is going to go across the board for all of these. You need to watch out for infection, right? They need to make sure they're taking extra precaution for this sort of thing. You even used to use gold compounds. Those are mainly for patients who have really good insurance, right? Just kidding. No, we use that occasionally. But again, a lot of metals, a lot of heavy metals are potentially used to be used a long time ago because they are somewhat cytotoxic. However, there's lots of side effects that are associated with it. So gold used to be used as an anti-rheumatic drug. Let's see, what else can we used to use? Silver has some antimicrobial properties. So I don't know if I mentioned this, but you guys ever heard the term born with a silver spoon in your mouth? What do you think that refers to? You think rich people. Actually, it was referring to healthy people because silver had antimicrobial properties, and so they said if you had a silver spoon in your mouth, you were less likely to get infections and say you were very healthy. So it's kind of a common misconception there. So you can go wow your friends with your very niche sort of knowledge of idioms. Anywho. But these are some older ones. We still may see some of them being used occasionally, but in general, they're focused on decreasing the activity of the immune system to allow for that inflammation to be decreased, right? To help to prevent the joint from being further destroyed. So we don't know the full mechanism of the DMARDs. We'll look at a few of them, but we're going to find that in general, methotrexate and hydroxychloroquine are going to have the best efficacy to toxicity ratios. And in general, you should start with one of these for most of your patients. Methotrexate is probably the most common one being used here. And you'll find that, with just methotrexate and corticosteroids, more than 50% of your patients should be able to be managed with that for more than 5 years. So again, start early. Help to save the joints the best you can, and these are two of the more common ones you're going to run into. But you may need multiple DMARDs, and we'll talk about a little bit later what kind of makes sense from a combination standpoint. Obviously, you don't want to use two drugs that have the same mechanism because you don't really get any additional benefit. However, there's going to be some concerns about mixing biologic versus non-biologic, etc. So we'll look at that more in detail a little bit later. However, most patients should start off with methotrexate. And we have a lot of good long-term data with this one. It tends to be mostly efficacious and mild from a side effect standpoint compared to some of the other ones. Also, it's a good backbone to a lot of other regimens. So you can use methotrexate plus something else in a lot of cases, and we'll look at that later. So traditionally, the DMARDs take time to kick in, so up to 3 to 6 months before you start to really see them have their full effect. So again, these are not going to be something they're going to see a difference tomorrow. However, that's what your NSAIDs for. That's what your corticosteroids are for, to help kind of manage our acute symptoms while these other drugs kind of kick in. Some of them may have a little bit faster onset, maybe some results within 1 to 2 months, but you really need to give it a full kind of 3 to 6 month period before you really evaluate to see how well it's going to work for them. However, on the other hand, biologic DMARDs usually kick in within a few weeks, and that'll make sense based on their mechanism, how they can directly target one specific mediator, like interleukin-6 or tumor necrosis factor, directly bind to it and inactivate it. So those work a lot faster for that inflammation there. Now again, therapy is going to result in immunosuppression, so it's really important, especially with the biologic DMARDs, test for TB beforehand. Why do you want to do that? Yeah, they have a latent TB infection that could activate as soon as you start to inhibit that immune system, right? So be careful with that. And then also want to make sure their vaccinations are up to date. You guys know any vaccinations you want to avoid in patients like this? Live attenuated vaccines, right? So there's different varieties. There's killed vaccines, which are basically the organism that has been inactivated, right? So that's another term for inactivated vaccine. There's live attenuated, where it's actually the virus or the bacteria. However, it's been kind of made. It's kind of a wimpy version of it, right? It's kind of been made less virulent, I should say, and can still have a good immune response to it. However, for these patients, what can happen if you give them a live attenuated version? Yeah, they can actually have activation of the disease. So that's why we recommend for like the flu. Flu comes around every year. We have lots of patients who need to be covered for the flu. We say, well, don't get the flu mist. That's the intranasal form, because that's a live attenuated form. Get the intramuscular, which is an inactivated form of the flu, right? So that's an important consideration. Make sure they're getting the right types of vaccines, okay? All right. So again, basically try to give it before initiation of the biologic DMARDs whenever possible, because that's going to give. Because again, if you're tamping down the immune system as well, how do we get immunity against these vaccines? By having an active immune system. So if I'm knocking that down, I'm not less likely to get a good durable response to that. So again, you're going to find the efficacy of the vaccines diminished because I'm inhibiting my immune system, right? Make sense? So killed or recombinant vaccines can be given during therapy. So that's like the pneumococcal, the IM flu, Hep B, those are all fine. However, live vaccines are not going to be recommended, as I said here. In fact, they will make different recommendations for people who are on immunosuppressive therapy. So for instance, the American College of Rheumatology recommends herpes vaccine at 50 rather than 60 because that risk is increased there. Anyone know where to get the kind of most up-to-date recommendation for vaccines? CDC. Always go to the CDC. For my purpose, I'll never have you memorize a vaccination schedule because guess what most people do when they work with vaccines? They look it up, right? They have a poster on their wall. They'll just go look at it and be like, okay, you're how many months old? All right, this is the vaccines you're going to get. I always thought that was silly to try to have people memorize that. But if you work in peds exclusively, you're going to memorize it by just using it all the time. However, it's like it's kind of not really our purview here. You can look it up, and the CDC has really good tables and everything. It'll kind of tell you exactly what to get when. Anywho, so starting off with methotrexate, we know this is working by doing what? How does it work? All right, it's a folic acid antagonist, which means, what does that mean for us? Yeah, inhibits DNA replication, right? So remember, it's affecting quickly dividing cells first. So what are our quickly dividing cells? Hair cells, GI cells, and the immune system, the immune system as well, right? So that's the other big one. So by inhibiting DNA production, you're inhibiting replication of these quickly dividing cells. So again, that informs a lot of the side effects and the clinical effect we see here. And you guys remember the antidote to give to reverse it? Folinic acid, right? That's the activated form of folic acid. There's another one. Glucarpidase, that's the other big one you sometimes use for like cancer patients who can't clear the drug. It'll just directly cleave it. Yeah, we do bicarb in order to help them clear out of their kidneys a little bit faster. That's usually reserved for patients who are getting really big doses. Like these patients for RA, they may be getting like, say for instance, like 25, 50 milligrams of methotrexate a day versus like these cancer patients are getting grams of methotrexate at one go. Those are the ones you have to be worried about them clearing it appropriately where they get the bicarb and all of that. This is not going to be on that same scale. So oftentimes you'll see that we'll recommend giving, say, folic acid, say one time a week or say daily, but usually very low doses, like say 1 milligram or something like that a day, in order to help kind of stave off some of these adverse effects. You don't need a ton of it, but we will give some folic acid, even though we know folinic acid is really the true antidote there. Anywho, again, just looking at the structure or the mechanism here, tetrahydrofolate versus methotrexate, very, very similar, very easy for them to get confused by the enzymes within the cells here. Basically inhibiting DNA replication, you inhibit new white blood cells from being made, you're immunosuppressed essentially. So we know a lot of those side effects that go along with that. We've already covered these, so I'm not going to belabor the point here. But again, be careful in patients who are pregnant. Obviously, this is going to be teratogenic because guess who has rapidly dividing cells? The fetus, right? So you probably don't want to inhibit that. You want them to make their cells like they should. Renal insufficiency, be careful with that because these older patients have poor renal function. They're not going to be able to clear it as well. So think about that. Chronic liver disease, you can see some hepatitis associated with this, hepatotoxicity, and then obviously, thrombocytopenia, leukopenia. Be careful with that as well because it will worsen that potentially. Again, this is the most commonly used DMARD for rheumatoid arthritis and, again, a lot of other conditions as well. And you should be able to see some effect within 1 to 2 months or so. And for the most part, since we're using lower doses, it's going to be pretty well tolerated for most patients. Now, there's a couple different ways you can do it. You can use it PO, which is probably the most common one, but some people will have it administered, say, like every week or every few weeks, either subcutaneously or intramuscularly. So there's some options there. However, as far as monitoring goes, look at the CBC. Look at their LFTs, serum creatinine, and make sure you're monitoring this as time goes on. Some of your patients may not need pregnancy tests, especially if they're like postmenopausal, things like that. However, make sure you're monitoring for these other things as well. And again, you can give folic acid. It helps to stave off some of the side effects. However, it's not going to be a cure-all. They can still definitely have some adverse effects from these drugs. Okay. Next, we have leflunomide, which is also going to be an anti-metabolite. This actually inhibits pyrimidine synthesis, and so this will help to actually prevent lymphocyte proliferation, essentially, right? So similar kind of end effect as you see with methotrexate. This is actually a prodrug. We saw teriflunomide is what it gets broken down into, which we saw with MS. So it's actually another drug you'll see used there. And again, similar efficacy to methotrexate. You can see the benefits, within a month or so. So pretty fast acting compared to some of your other traditional sort of DMARDs. However, you got to be very careful because remember that this drug undergoes that enterohepatic recirculation, right? So it will be kicked out via the biliary tract and then be reabsorbed. So it sticks around for a very long time. So think about if your patient wants to get pregnant ever, they're going to have to go through that cholestyramine washout where they basically will give cholestyramine, will bind it up, and then they can eliminate it in the feces. Because otherwise, it's just going to be there for months and months and months and produce a teratogenic effect, essentially. But again, similar monitoring is what you'd see with methotrexate. Next we have hydroxychloroquine. This one's going to be kind of the least efficacious, but also have the mildest side effects out of the bunch. And so this is good for patients who are starting out with really mild symptoms, really not so severe. If you catch them really kind of early, and so not going to be good for forever. You might have to switch them over to methotrexate eventually. However, it can be useful for doing things like inhibiting neutrophil locomotion. Chemotaxis of the eosinophils tends to go down. So again, it's not working directly to inhibit white blood cell reproduction. So that kind of goes to show you why it's not having as many side effects, right? It's not as immunosuppressive as methotrexate because it doesn't really kind of inhibits the cells that are already there. It doesn't help to inhibit new production of cells, essentially. A little bit slower onset here, but less monitoring because there's no really mild suppression associated with it, no hepatotoxicity, no renal insufficiency. So if you catch them early, very mild symptomatology, then you can go ahead and use this first, and that would be appropriate. Right? Is there like a definitive test you can do for RA? There's some markers you can look for, but is it easy to catch super early? No, usually they're symptomatic. It's usually why they're presenting and being evaluated. So it'd be nice if you can catch them as early as possible, but it may not always be the case. As far as side effects go, you want to take it with food because it can cause some, nausea, vomiting, diarrhea. But the more kind of unique things to worry about with this drug is the retinopathy that can occur. So you can see some blurred vision, some accommodation effects, and it can also cause some increased skin pigmentation. So there's some discoloration there you might see due to hydroxychloroquine. So those are kind of unique things you want to be keeping in mind for this particular drug. Sulfasalazine we've talked about before in the context of UC and Crohn's disease. Again, this one gets cleaved by those colonic bacteria, and it helps to produce sulfapyridine and then also 5-aminosalicylic acid. This is chemically related to what other drug? Aspirin, yeah. So aspirin we know is an NSAID, and we know it has anti-inflammatory properties, so we can see why that might be beneficial for rheumatoid arthritis, right? But that sulfapyridine is also probably helpful in helping to inhibit, TNF, helpful for like free radical scavenging effects, So again, can be used as a backup, probably not first line like methotrexate is, but you can see a response here, 1 to 4 months or so. So as far as side effects go forward, again, watch out for elevated LFTs, some alopecia associated with that. Again, start with the lowest dose you can, try to titrate up to see what they respond to. And you can see some leukopenia, but probably not as severe as you would see with like methotrexate or as common. Now, one thing to keep in mind though is these drug interactions here. So why do you think antibiotics would be an interacting category here? How do you say the drug gets activated? By the colonic bacteria. So if I give antibiotics to wipe out those colonic bacteria, guess what? Drug doesn't get activated, right? So that's an important interaction to keep in mind. Things with like iron supplements can end up binding up to it and prevent it from being absorbed very well. And then things like warfarin can have some protein binding interactions, right? If one drug comes and kicks another drug off the proteins, you can see increased effect of that drug that got kicked off. So increased risk for bleeding and bruising, things like that. The other big thing to note, turns your urine and stools yellow to orange. Always warn people if you change the color of the urine or stool because it can freak people out, right? Okay, so those are the traditional DMARDs we're talking about. Here's kind of a new one called tofacitinib or Xeljanz. And so this is actually going to be, because you can tell by the IB ending right there, similar to some of the chemo drugs we talked about, these are going to be a tyrosine kinase receptor inhibitor, right? So it's kind of the normal nomenclature. So if you think about gefitinib and imatinib was the other big one, Gleevec. So those are all going to be tyrosine kinase receptor inhibitors. So you can see this tyrosine kinase receptor. Basically, there's this JAK inhibitor, or this JAK protein, which stands for Janus kinase, and this is going to be important in this kind of signaling process for increasing inflammation. So that's really the basic thing you need to know, is that when you have this receptor activated, it's going to lead to transcription of these kind of inflammatory proteins. By inhibiting this, by giving the drug that blocks its activity here, you're going to find that it will interrupt that signaling process, and you have less inflammation as a result of that. Okay, this is really the extent that we need to know about it, because it's inhibiting these STAT proteins, less inflammatory gene transcription. So it's another orally available medication, which is good, because if you look at your biologic agents, how are those normally given? Usually either IM or IV for the most part, right? Because again, they're proteins, so they'll have a hard time being absorbed orally. But a lot of the traditional ones we were talking about, all those are oral agents. This one's available orally, so think about what's kind of good for your patient from that perspective. This one is starting to be used either as monotherapy or sometimes in combination with some of our other DMARDs. However, we're going to find that you do not want to use it in combination with other biologics. The reason for that is because of the immunosuppression effects it can have. That if you have too much immunosuppression by mixing a biologic with one of these, you can end up seeing increased risk for infection, right? So we want to be cognizant of that. So it would be okay to mix it with like methotrexate plus Xeljanz. However, you would not want to mix rituximab plus this. And we'll talk about the biologics in a second here. You can watch for renal dysfunction, look for hepatic dysfunction, and if you have any CYP3A4 inhibitors on board, this will increase levels of this drug and increase your risk for infection there. Obviously, test for latent TB as well with this one, because it can be pretty potent in inhibiting the immune system. And then from a black box warning standpoint, there's some concern for serious infections, and then some risk for lymphomas and other malignancies. So just know those are some concerns. This is probably the newest out of the bunch. And so, it's going to have the least amount of kind of experience with its use. So probably not used first line in a lot of cases, but maybe a good backup if patients fail kind of other therapies. Okay, so moving into the biologicals. You okay back there? Starting to spring break a little early? There you go. All right. Anywho, so the biologic. So one of the things we'll see with this is that we like to use the traditional DMARDs first because they tend to be a lot cheaper than your biologics. They tend to be very, very expensive because they are protein-based products. We have to make these recombinantly. But on the flip side, there's very little monitoring associated with them. Certainly you monitor infection, it's a big thing. However, they're not causing any kind of decrease in production of inflammatory cells and the white blood cells. They're just usually inhibiting them in some means, or trying to sequester those mediators like TNF alpha. But these are going to be very immunosuppressive, so risk for infection, increased risk for TB, so you have to test for TB beforehand. And then if the patient actually has an active infection, this may be a cause for discontinuing use. So that way they can fight off the infection, you can put them back on these medications. Just being aware that you have to worry about flare-ups of their disease, and you have to treat through that, which we'll talk about in a minute here. And then don't give live vaccines, we already covered why that is. So the TNF alpha inhibitors are probably going to be the first ones that you'll jump to. All going to have similar side effects, similar contraindications. One relative contraindication to note here is you want to watch out for patients with CHF, because there has been an increased risk of death associated with things like infliximab and etanercept, and causing either exacerbations or causing increased risk of death associated with that. So the worse CHF that they have, you want to avoid utilizing these medications. So again, this might be better for traditional. Xeljanz might be a good option for them. Just be careful with that. And with MS, there's a risk they can actually induce or exacerbate symptoms. I don't know actually the mechanism for that, because you think if anything it might help. However, you want to be careful with using it with MS patients. But there's a risk for lymphoproliferative cancer. That kind of makes sense, because if you're inhibiting your immune system activity, it's going to respond by trying to produce more immune cells. And so you can kind of see why that would be a risk with that one. Okay, so the first one we have here is going to be etanercept or Enbrel. This one's kind of interesting because there's actually two tumor necrosis factor receptors linked together. So basically, it will bind to TNF alpha, and once it's bound up, it won't kind of let it go at that point. And so these you'll find you can use a biologic plus a non-biologic together. That's okay. So like methotrexate plus etanercept is a decent combination. Again, you're going to get more benefit than either one by itself, because there's some synergism there, different mechanisms essentially. But typically, because of its expense and risk for immunosuppression, they typically are going to be given as kind of a second-line agent versus using methotrexate by itself. This one, you're going to find that different dosing frequencies are needed for these products. They typically last longer than like an oral-based product. However, some of them are given twice a week. Some of them are given every other week. Some of them can be given months apart. Just depends on the medication. And you'll kind of get familiar with that if you work with these patients. But again, very expensive. This one's about $15,000 a year. This is probably one of the cheaper ones out of the bunch, I would say. Next one's infliximab or Remicade. So one of the things to consider, and I mentioned this before, but again, these proteins are not always going to be fully human proteins, right? Some of these are going to be a mixture of mouse proteins. Some of them are going to be, human and mouse. Some of them are just mouse. So whenever you see an X here, that usually means it's chimeric, which means it has part mouse and part human. What do you think that matters clinically? Why do you think it would be a big deal? Right, so our bodies are generally, we do not treat a whole lot of mice with rheumatoid arthritis. However, the humans we treat typically don't have a lot of mouse proteins in them. So you're more likely to have a reaction to that from an allergic standpoint. So the more chimeric products you give, the more mouse protein you're injecting into a person, the more likely you are to see a reaction. So if you see an X in there, these are one of the things you have to consider is, are they going to have an allergic reaction? Do I need to treat through that? So, and not only just pure anaphylaxis, but you can have anaphylactoid-like reactions prior to that. So you can get a lot of itching, rash, potentially hypotension associated with that. So you got to watch out for that. So anyway, this is working by binding up TNF alpha directly and decreasing the symptoms associated with that, because again, it can't activate those T cells and B cells like it would normally. We would normally use this as a second line for patients who maybe cannot tolerate a normal standard DMARD by itself. And it's been shown to be pretty safe and effective when mixed with things like methotrexate. So you can, again, use it for good combination therapy. What's interesting, though, is that for some patients, you may find that they actually will develop antibodies against this protein, right? So having antibodies against these antibodies. And what that will do is it will inactivate them and make them less effective. So what we can do in those cases is actually give it along with methotrexate, and that will help to interrupt that antibody production and prevent the infliximab from becoming less effective. So sometimes you'll see that combination there to try to help keep activity of the infliximab longer than you would have normally otherwise. So it can be a thing to consider there. Also, the more antibodies we're making towards this infliximab, guess what? Your risk for anaphylaxis goes up as well, so you have to be really careful with that. So a lot of times when these patients are getting these injections, we will pre-treat them with things like corticosteroids, or we'll give them Benadryl beforehand, because it will help them limit some of those reactions they're having there. So again, something to consider. So just to give you an example how often this one would be given, this one would say, give give it at day 0, then at 2 and 6 weeks after the first dose, and then every 8 weeks. So kind of once they get kind of stabilized, it would be every 8 weeks they're having to come into the infusion center to have it infused, and then that's it. Versus taking a drug orally, they would take or at home potentially. And so we have to infuse it over a slow period of time because we have to worry about those reactions. So I kind of talked about that already. You want to have Benadryl on hand. You want to have things like steroids on hand to treat those reactions. And then ultimately, if they have a true anaphylactic reaction, what would I give them? Yeah, epinephrine would be so usually you're going to have standing orders available for those patients. We'll have Benadryl, corticosteroids available. Sometimes you'll go ahead and give them Benadryl beforehand just to try to stave off any reaction, and then you'll have a dose of epi ready to go just in case they have a anaphylactic reaction to it, right? So you want to have that at the bedside ready to go in case you need it. Another common one is called adalimumab or Humira. This one's actually kind of nice because it comes in a pen form that the patient can actually go and inject subcutaneously themselves. And so it's nice because they don't have to come in to the infusion center and have this infused into them over the course of several hours. But very similar mechanism of action to infliximab. Notice here it doesn't have the X there. So this is actually because it has a U. That means it's all human protein, so it means it's much less likely to have a reaction to it, which is good as well, because if a patient's injecting this at home and they have an anaphylactic reaction, that's an ER visit, right? Versus they're just an infusion center, you can kind of treat through that. Very similar place, used as kind of a second line if your traditional DMARDs are not working well enough on their own, and very similar risk for infections associated with this. And again, this one would be 40 milligrams sub-Q every other week. They just have a pen they'd be prescribed, they can take home and just inject every other week there. And I think, did I give this as one of your assignments on the prescription thing? Yeah, so you'll get to write a prescription for this and try to figure out how to write that one to make sense and for the pharmacist to fill and all of that. So that'll be fun. Next we have abatacept or Orencia. This is actually a co-stimulation modulator. So this is kind of interesting. It's a little bit different mechanism. It'll actually bind to CD80 and 86 receptors and actually prevent some of the crosstalk between some of these inflammatory cells. They can't kind of interact with one another to activate further cells. So less T cell activation by blocking these receptors here. So kind of a novel mechanism. And again, sometimes used by itself, sometimes in combination. But if patients are failing a TNF alpha blocker, so if they fail infliximab or if they fail Humira, this is a good backup method. You can use this instead potentially. So again, not first line for this from a TNF alpha from a biologic standpoint, but can be used afterwards. Next we have rituximab, and again this is an X here, so it's chimeric protein, so and risk for anaphylaxis is a lot bigger. This is another one that's going to be binding directly against CD20 on B lymphocytes. So basically you're trying to cause a very big depletion of your B lymphocytes. This one is very, very potent at decreasing the immune system, but very likely to cause infection in a lot of cases. So you have to be careful with that. And it can take months after discontinuation of therapy for the B cells to really kind of replenish themselves. So it can be pretty potent there. But it's good if patients have failed methotrexate, they failed TNF alpha, they can go to rituximab and use that instead. Now, this one has to be pre-treated with because the risk for reactions is so high. Patients have to receive Benadryl, they need to receive corticosteroids, and then get the infusion of the drug, and then have medications on hand in case they have a further reaction. So that's one of those things we have to really make sure we have orders for, because otherwise, the patient can have a reaction to it. This one, tocilizumab or Actemra, is an IL-6 antagonist. I'm actually starting to see a lot of this being used in our infusion center. Starting to see a lot of rituximab, a lot of infliximab, but tocilizumab is starting to come up and being used for some of our GI kids. Of UC or Crohn's, starting to see this more with JRA or juvenile rheumatoid arthritis. So this one's getting a lot of use nowadays. But used as a backup if they fail TNF alpha inhibitors, this is a good one. And this will bind just to IL-6 instead of TNF alpha, so just a different inflammatory mediator. The only thing unique with this one is it's going to induce CYP3A4. It's kind of unique. You don't see a lot of CYP3A4 inducers. You guys know any other ones that induce CYP3A4? So I think like rifampin, remember rifampin was a big one, anti-infective that actually induced CYP3A4. But can affect things like birth control, your statins, your warfarin. Affecting the birth control can be a big deal because, again, a lot of these drugs these patients are taking are what? Teratogenic. So if a patient gets pregnant on an accident because their birth control failed, that could be a problem, right? So these are things to consider. Yeah, so if I had a patient who's on birth control, I would say definitely use a backup or potentially utilize a non-oral oral contraceptive. I think we do OB-GYN later on, right? We haven't covered it yet. Yeah, so we'll talk about it later. But using like a non-oral version where it doesn't, you don't have to worry about the first pass effect can be sometimes useful there. Yep. Or use like an intrauterine device or something where you're just getting a local effect, like a Mirena, or if you use like a copper one or something. We'll talk about this later. Okay, so about 30% of patients will fail their biologic agents, and some of it will be due to a primary lack of efficacy, where the drug itself really just wasn't working over the course of 3 to 6 months. Sometimes they'll have a secondary lack of efficacy, and this is going to be when you have a failure after they initially respond. A lot of this is due to them developing antibodies against these proteins, so you can start seeing them becoming inactivated and not working as well. And so this is where you may add on, say, like a non-biologic DMAR, like a methotrexate, and that will help to mitigate some of that. So again, just little things you might see being done over time to some of these to try to retain efficacy of these drugs here. Now, the big thing to note is if you fail a TNF-alpha inhibitor, you can switch to an IL-6, right? You don't necessarily want to switch to another TNF-alpha inhibitor. It's better to switch between mechanisms, essentially. And generally, do not want to use 2 biologics together because the risk for infection is so high at that point. It's really not going to be worth it. But you can do a biologic and a non-biologic, just not 2 biologics together. You can do 2 non-biologics together. That's okay. Not 2 biologics. Got it? That may come up on a test at some point in your future. I don't know. You'll forget all of this through spring break, but hopefully you'll remember it when you come back. But anyway, so just briefly, our corticosteroids, these are going to be good for both kind of acute exacerbations. They're good for kind of long-term management because they're very good at being anti-inflammatory agents. They're immunosuppressive. And so we know a lot about these already. We know their side effects. So what are some things I would worry about with giving corticosteroids? Infection is obviously a risk, right? What happens to people's glucose? Goes up, right? What happens to their mood? They get kind of irritable. Yeah, some people have kind of worse effects than others, but elderly patients, so they can have some altered mental status associated with this. What does it do to your weight? Goes up, right? Because you have more fluid retention, right? These are things to consider, and especially if you're doing this on the long term. What about older female patients? What are corticosteroids going to do to the bone? Yes, we're going to start leaching calcium. We're going to have more risk for osteoporosis, right? These are all things to consider when dealing with corticosteroids. So again, we'll sometimes see these being used for chronic therapy. We try to limit it as much as we can, but the main goal is to use as low a dose as possible for these patients. But in a lot of cases, you'll see them being used for disease flare-up. So having like an acute flare-up, you can utilize this. And in some cases, we'll use for what we call bridge therapy. Anyone know what that means?
You're switching to another drug?
Yeah, or maybe if you're giving time for like a DMAR to kick in, you're using the corticosteroids to cover them until you give it a month or 2 for it to kick in, and then you can just try to wean them off of that, right? And again, when do you need to wean off corticosteroids? If you're using it for more than a week, you need to do a wean off of it, because otherwise you worry about that adrenal suppression, right? Sometimes we'll use intramuscular steroids for kind of a short-acting kind of burst therapy for kind of an acute flare-up. But just remember, we also have some long-term depot forms that are available as well, which is nice because they have a kind of a natural taper to them. So if you do like a big shot of like methylprednisolone or something that's meant to be a drug called Depot-Medrol. If you see a depot on it, it usually means it's going to be an intramuscular injection that sticks around for a long time, maybe 3 months or so. And so that'll have a nice taper effect, and you don't have to worry about tapering that because it does it itself, essentially. The other big thing we'll do occasionally is called intra-articular injections. This is good for small number of joints that are being affected here. The nice thing about giving intra-articular injections is it limits systemic effects. You'll still get some leakage into the systemic circulation. However, it's much more limited than you would see with like an IV dose or an oral dose. So it can be sometimes useful. However, the big thing with intra-articular injections, you do not want to do it more than 2 or 3 times in a year. The reason for that is because you can see increased joint destruction and tendon atrophy due to this. Okay, so you can do more damage, do more harm than good if you give it too frequently. And this will go over the same when we talk about it for osteoarthritis. Okay, we talked about the side effects. Again, use the lowest dose possible. You need to titrate off if it's been more than a week for them, right? Okay, so any questions? I will let you guys go now. Have a wonderful spring break. I'll have a quiz ready for you when you come back in 2 weeks, right? 2 weeks. I won't show up next week. You guys won't show up either. And we'll go from there. Right. Thank you.